Steve Fehlauer, who is our keynote speaker today. 5 years ago, when I was really struggling, I didn't know where to turn. Things had turned upside down in our lives. Somebody said, well, go see Dr. Fehlauer at Silverado. He can help. And so I sat down with Dr. Fehlauer, and the first thing he said is, I've seen 10,000 cases of dementia. And not knowing who I was, he looked at me and he said, and you'll be my 10,000 first case. But it was for my wife, it wasn't for my wife. So, Dr. Fehlauer, Director of Medical Care at Labile.
Good morning, everybody. I really appreciate Marsden and Lynette and the foundation for inviting me to speak today. I personally have cared for a woman with Alzheimer's disease, my mother. And so I want you to know I have lived the experience that you're all living. And when Marsden asked me to speak, I said I really need to talk about how a caregiver gets help from their physician. And so that's going to be the focus today. And I have a lot more in my slides than I ever going to be able to cover for you all. So I'm going to go pretty quickly because I really want you to be able to ask questions. Most of the time when I give these kinds of talks, someone asks me to go out and speak about this. I say I'd really prefer to do a Q&A. Because what's on their minds may not be what's on my mind. And that brings up the fact that you're all living in my reality for the next hour, okay? And I say that as a joke. But when you're caring for a person with dementia, you're living in their reality, okay? And that's a critical thing to remember and a big part of what I'm going to talk about today. Because when I attempt to treat someone with dementia, the most important thing for me is to try and get at where they are cognitively, where they are emotionally, and why those things interact to lead to them feeling bad, anxious, worried, depressed, or them acting out, combative, resistant, angry, irritable, okay? Because only from their perspective can I do the right thing medically. And that gets to the point about, well, what can you expect from a doctor, right? Well, it depends on the kind of doctor you go to. If you go to Marsden, Marsden's going to listen to your complaint for a couple of minutes and then say you need surgery. Okay? If you come to see me, I'm going to listen to your complaint. I'm going to think about it for a while. I'm going to say, well, I have to order $1 bazillion worth of tests, and the tests are not going to give us a definitive diagnosis, but it will rule out the things that we can treat. And then I'm going to prescribe you a handful of meds. And the next time you come see me, I'm going to prescribe you another handful of meds. Because that's all I've got. I don't have the motor skills to operate like Marsden does. Okay? So, when you're dealing with a person with dementia, how do you get the right information into the hands of the doctor so that they can write the correct prescriptions or discontinue the bad ones? That's basically what I'm going to try and walk you through today. And how to talk the doctor talk, and what kind of observations to make, and how to present them. When Marsden and I were in medical school, we had to present cases to the attending physician on rounds. And you were given 5 minutes to tell the story. Well, in the doctor's office today, if your internist is in a typical practice, he has to see 10 to 15 patients in an 8-hour day. So you do the math on that, and you've got about 15 minutes to see your physician and to tell the story and get the thing done. So if you listen to me today and you collect the information and you can tell the story in 5 minutes, you're more likely to get the kind of treatment that is necessary. So I'm sitting here reading my Twitter feed, and which is totally useless and full of bad information this morning. And this poem popped up that I want to share with you. Why some people be mad at me sometimes. They ask me to remember, but they want me to remember their memories, and I keep remembering mine. Now, this was written by a black woman, and it's about racism, and it's about the treatment of black people in America. but it applies to our patients and our loved ones with dementia as well. We want them to remember reality, and they are living in their reality and remembering that. And they get mad at us, and we get mad at them. So 2 important things right off the top. Something that changes suddenly is because something has suddenly changed. So dementia is a long process, typically with insidious onset, loss of memory, impairments in ability to function. Stroke is something sudden. Okay? A person with dementia who is coasting along on a certain plane and suddenly has a new behavior or a new physical anomaly or a change, it's because something sudden has happened. And that something sudden is often treatable. It's like, just stop the medicine the doctor just prescribed. Okay? Or it's treat a bladder infection. Or it's treat constipation. Or it's treat dehydration. Okay? So that's delirium. It's a sudden loss of function that's reversible, as opposed to dementia, which is a chronic irreversible condition that's relatively stable over time with ups and downs. Okay, I'm going to briefly tell this story. Normally I incorporate quite a bit of it, but I'm going to tell the whole story now. So we had a client at the Auberge who was a professor of languages at the University of Utah, and he was a very stuffy guy. Even in his dementia, he would wear a coat and an ascot, and he would strut around in his "I'm the professor of languages" attitude all day long. Okay, and yet he was also on top of that. So that's the context of who he was. All right, that's the life he had lived and the person he felt himself to be. But he was also demented, which meant that he was confused, disoriented, labile, resistant, and delusional. And I was working at more than one facility in these days. And I was at another facility, and I received a call. And they said the professor, which is what we called him, came into the tray line at the Auberge, which is like a cafeteria line where they would line up the different special diets for the patients. And he took a tray that wasn't his, and when we tried to stop him, he threw it at the person who was behind the tray line. He threw it at the cook. Said, "You need to do something." Well, I'm in another place, and I don't want him to hurt himself or other people. He's aggressive. He's hostile. So I prescribe a medication. The next day I'm at the Auberge, I go in, and I'm going to collect the information because it's important. And I go talk to the line cook. And the line cook says, "Yeah, the professor was in here yesterday. It was a diabetic diet. He doesn't have a diabetic diet. And I had just prepared it for somebody else, and he picked it up, and I told him, 'That's not your lunch.' And he said, 'But it is.' And I said, 'No, it's not. Your lunch is going to come at another time.' 'No, this is my lunch.' And I kept trying to tell him that he would get his own food, but he wouldn't listen to me. And I said to him, 'Put it down and I'll get you a meal.' And he threw it at me. I said, 'Now you've had a chance to reflect on that. What was the right thing to do?' I should have let him take the meal. Yes, you can make another meal. All right? So I did the wrong thing. I heard part of the story. I did what a doctor can do. I gave him a medication he didn't need, because what he really needed was to be treated like the person that he was, living where he was, and he wasn't going to harm himself or others if he walked away with that tray. Okay? So, in medicine, there are diagnoses and there are syndromes. A diagnosis is you take a piece of tissue off of someone, you slice it up, you look it under the microscope, you show it to 3 other pathologists, they all agree that this is melanoma, and it's not basal cell carcinoma. Okay? It's objective. You can take it out and look at it and see it. Syndromes are things that are collections of symptoms and findings, and you're holding up your thumb and you're saying, Alzheimer's. And I might be 70% correct, because it's probably Alzheimer's and vascular dementia. But I don't have an autopsy to prove it. And nobody volunteers for an autopsy. So I am left with this uncertainty in diagnosis. And so it's all syndromic based. Now, in the case of Alzheimer's disease, much has been done to advance the imaging for amyloid and tau protein, and there are tests of cerebrospinal fluid, and there are hints at a test that can be done in the bloodstream for tau protein, which will be more definitive in defining this as a case of true Alzheimer's disease before autopsy. But generally speaking, your physician will collect a bunch of information and do an examination and then make a best guess determination of what it is. So the syndrome of dementia delirium, is abrupt in onset, it's brief duration, with fluctuations in time, with impaired attention, disorganized thinking, altered levels of consciousness, sleep-wake cycle disturbances, psychomotor hyperactivity or hypoactivity, and associated memory impairment. And there's an identifiable organic cause. So I kind of listed a few of the things earlier. Medications are always at the top of my list because doctors are likely to prescribe a new medication for every visit to the doctor's office. And we often are attempting to do the right thing, but run into the interaction of someone's body and their mental activity that doesn't respond the way we expect to a medication. So it's not vindictive. The doctor's not trying to hurt them. They're trying to do their best. But the medication creates the impairment. Infection, trauma, dehydration. Those are the most common things. And persons who are elderly, who are not demented, are frequently delirious in the hospital. Okay, so sometimes I get notes from young physicians from the hospital that says that they have acute dementia. Okay, that's the way they think of it. Okay. Alzheimer's disease is insidious. The amnestic form or loss of memory is the most common type. The non-amnestic forms are visuospatial. I had a client when I was at the university who was suffering from dementia. He would walk up to the cabinets and his wife would say to him, "What is it that you'd like?" And he'd say, "I want to get a glass out so I can have a glass of water." He could not handle the opening of the cabinets. It just baffled him. Language impairments are common, inability to understand or generate fluent speech, and of course the executive dysfunction that robs you of the ability to manage your affairs and leads you to have someone assist in your financial and personal and maybe your social and your occupational functions. It's a memory and learning disorder. What do I mean by that? It is a problem of forming new memories at the onset of it. You generally have a preservation of your permanent memories and can recall almost all of your life events and things that are important, but you can't make a list in your head and keep it long enough to do the groceries or plan a meal. And that's the early stages. My own mother, who did the accounting for our family business, when I knew she was in real trouble when she could no longer balance her checkbook. Okay, she was high functioning in every other way, driving and everything else, but she could no longer keep her check register. The memory disturbance creates cognitive dissonance. It creates this mismatch between the reality that I have, which is I believe I can do all these things, and the reality that I can't. And persons early in the disease are often depressed by, I'm just not right. It's harder for me to do things. I can't seem to manage. I don't know what's wrong. And so a hallmark of late middle age onset of dementia is actually being depressed. It's a very predictive factor in identifying that dementia might be starting. So vascular dementias are different in that they tend to be abrupt in onset, although that's not always true. The kinds of vascular dementias that are caused by hyperlipidemia and atherosclerosis and diabetes can involve narrowing of the arteries of the brain, and the penetrating arteries of the brain, the little small arterioles that go to the center of the brain where the memory circuits are located, can starve that portion of the brain in a way that is discernible on CAT scans or MRI scans as what's called small vessel disease. So you might have had someone say to you, when we looked at the scan, we didn't see any strokes, but there's evidence of periventricular white matter disease or small vessel disease, like that part of the brain is just not getting enough oxygenated blood. And that can look like Alzheimer's, which is why I say to you that I'm about 75% likely to get it right, but the other 25% is probably going to be a combination of vascular and Alzheimer's disease. They do go together in old age. The mood and behavior disturbances in vascular dementias are more variable in cause and expression because they can be more sudden of occurrence, and the kind of injury can be localized. So, speech disturbance might be more common because that area of the brain was more affected, okay, for example. And the frontal lobe parts of it can be more pronounced. So the front part of your brain is where your consciousness resides. It's where you assess the environment, where you determine what it is that you're experiencing, how it is that you're going to respond to it. And so when that part of your brain is impaired, you can have less of a socialization in your emotional responsiveness. Okay, so it would be inappropriate for me to be offended by the things that Marsden said earlier and say something about Marsden right now. Okay, I know better. All right. My grandmother had a frontal lobe meningioma. She was the wife of a Presbyterian minister. She was poor. She earned her money by playing the organ for everybody in the small town that I grew up in. Didn't matter if you were Catholic or Mormon or any other religion. She did all the funerals and all the weddings. And over the course of decades had accumulated a small sum of money that she used to buy the first house she had ever had when she was in her 70s. I was in college. She started sending me $400 checks. She also started to tell dirty jokes. She also started to break into the front of the line at the Senior Citizen Center for lunch. Okay? She was desocializing. She came down to the University of Utah. Dr. Reichman cracked open her skull and used a spoon to take the tumor out. That's the way surgeons do things, right, Marsden? And she improved. Okay, the frontal lobe features went away. So this is an example of everybody who has dementia should have at least one brain imaging, because there are things that look like Alzheimer's disease which are not, which are correctable. Unfortunately, it's only about a 1 in 20 chance that there is something like that. Frontotemporal dementias are probably more common than was thought to be the case when I was in training. The exact cause of the frontotemporal dementia is not known. There are associated Lewy bodies and there are associated plaques and tangles, but they're not in the same distribution as in Alzheimer's disease, and they're not in the same intensity. It is associated with atrophy out of proportion in the frontal and temporal lobes, and they often have impairments in insight and judgment rather than memory disturbance as their initial manifestations, or speech disturbances in aphasia in understanding or generating speech. The social misconduct that I just described about my grandmother, and they can have withdrawal or apathy. They can also have activation. And on scan, you can see this disproportionate atrophy. And this is an example of where it may discriminate as to a type of dementia when you do a brain scan. I'll talk about this because it applies to management. When the frontal lobes are affected, you have these impairments in social and personal functions. You can also have perseverative or stereotype behaviors. So it's as if your frontal lobe is no longer doing its job of saying, this thing came up, okay, like I need to pay the bills, all right? And then you do it. And then you remember that you've done it. But in the frontal lobe syndromes, that remembrance doesn't occur, and you get in this loop, okay, where the only thing you can think about is, I've got to pay the bills, or the kids have to get home from school, or something like that. And you'll see people like this with dementia. And they can also have stereotype behaviors. Okay? They can be obsessed or about something, or they can have compulsions. My own experience is that restlessness and hyperactivity are more common in the people I have to treat than the persons who are apathetic. And that's probably because I deal with only disabled persons with dementia, the kinds of people who have to be institutionalized. And so because of that, a restless or agitated person is much less pleasant as a roommate than a person who is apathetic and withdrawn and quiet. Okay? They can tend to have labile mood. What do I mean by that? Once again, Marsden had to make fun of me for my first name is Charles. And so, I could have really jumped on him about that and done so inappropriately and stood up and yelled at him and screamed and threatened him rather than waiting until I was talking now and just socially berate him, which is much more appropriate. Dementia with Lewy bodies looks like Parkinson's disease but is not. It's most often associated with early problems with misperceptions, visual spatial problems, language production, reasoning, executive functions, rather than memory impairment. Okay? So you're interacting with someone who's not right in their functioning in their job and around the house, and they can look like this. And the intern in the clinic says, by cracky, it's Parkinson's disease, and gives them Cinemet, and they hallucinate, and they have wild behavioral disturbances, but their Parkinson's disease does not get any better. And because these people are prone to paranoia and delusions and hallucinations, the temptation is to give them antipsychotics, and when you give them antipsychotics, they lock up. More than once I have had to rescue somebody who was treated with antipsychotics with Lewy body dementia, who literally went to bed and could not eat or drink. Okay? So as I said, they're made worse with Parkinson's drugs. Hallucinations and paranoid thoughts are common, and people treated with antipsychotics do worse. All right. terminology of understanding the types of experiences that the person is having is really important. So now I'm going to start the part of the talk where this is how you tell the doctor what's going on so that you can get the right prescription. Context is key, all right? In journalism, there's the who, what, when, where, why, and how of writing a story, okay? So when we talk about the professor, the context was he's in a care facility, he's in the tray line, and he's interacting with the person who's preparing the trays. That's the context, all right? So another context would be, I'm the caregiver dealing with my mother who needs to have a shower, and I have to do that, okay? That's the context, all right? The other context is, what is that person living at that moment? What do they think is going on in their world? Who do they think they are? What do they think they're supposed to be doing? What do they think you are trying to do? Okay, that's all context. And there's provoked and unprovoked behaviors. A provoked behavior is me, a child, attempting to undress my mother and throw her in a hot water bath, right? I'm provoking that behavior. She rightfully is confused. She rightfully is resistant. She's rightfully the parent and should be the one in charge of telling me what to do, not me telling her what to do. Okay? Unprovoked behaviors is the woman who interacted with my mother in the assisted living memory care facility with the idea that my mother had an affair with her husband and pushed my mother down and broke her hip. Okay? So the context was that the person interacting with my mother had a belief, a false belief, a delusion, about my mother, which my mother did nothing to provoke, and suffered an injury from this unprovoked event. Unprovoked events are bad news in care facilities. And they're bad news for the person who is having the event from their perspective towards another. So for example, this woman who attacked my mother, it's bad for her because she's living with something terrible inside of her, and she's acting out, and she's acting out in a way which is a threat to herself and others, and that's the worst kind of thing to try and medicate, because I'm going to take away her feeling of self, okay? I am going to medicate away her idea of who she is so she doesn't act on it. That is awful from a doctor perspective. And it's terrible from a family perspective. Because at that point, they're really getting more constrained, not just by their disease, but by things that people do to them, like medicate them. Okay, hallucinations. There's a common misperception, even among practitioners that I interact with, that what a hallucination is versus a delusion. I hear Betty says that she was talking to her mother, so she's having auditory hallucinations. The answer is no. It's more likely that Betty has a delusion that she talked to her mother. She believes that she talked to her mother. Because the likelihood of an actual hallucination occurring outside the setting of delirium or in Lewy body dementia is really uncommon. Okay? So if you actually observe someone talking to their pet dog that they point to on the floor, that's a visual hallucination. If you actually observe them having a conversation with someone in the room, that's an auditory hallucination. Okay? If you see them manipulating something in the air and they tell you that they're trying to untangle the fishing line, that's a tactile hallucination. If they smell something that nobody else can smell, then that's an olfactory hallucination. Okay? Delusions are a fixed false belief. Delusions are extremely common in society. Does everybody agree about that? Okay? And the delusions that persons with dementia experience are based in who they are. Okay? So, the delusion my mother had was that she did not need help with a bath, when in fact she needs help with a bath. She couldn't do it herself. Okay? So, this creates, again, this cognitive dissonance, where everything in the world around me is telling me things that I know to be false. All right? And the worst thing to do is to argue with them. Okay? You instead have to charm them. You have to engage them. You have to bring them along as much as possible. Because once again, if they are combative and resistant and hostile and angry, and you ask the doctor to intervene, I'm going to take away their personality. I'm going to shut them down. So, this is where all of the other stuff that you've been hearing about the last couple days, about distraction and engagement and all of those things are so important in caregiving. Agitation and aggression are driven from within. It's based on an idea in the person's mind. Okay? Agitation is my way of describing it, and expecting it described to me, is the restlessness, the pacing, and the exit seeking, this physical activity that's manifest as this behavior. Aggression is a verbal attack. Stop that. You're hurting me. You've put me here. Okay? Or physical resistance and combativeness. So, again, I attempt to disrobe my mother against her will without engaging her and having her participate in the process by pulling her pants down, and she reaches around and she smacks me on the head. Okay, that's aggression. So restlessness versus aggression. And the aggression can be verbal. Fear and anxiety, it's often based in cognitive dissonance. The world around me doesn't make sense. I don't understand who this person is. I'm afraid of them. Why is this person approaching me? Okay? And it can result in resistance and combativeness. But again, that's based on the false idea in the brain about the event. It's an internal thought of discomfort, and you can express it by saying that you're worried about something. Okay? Agitation can be a manifestation of an anxious thought. I need to get home to my children. They're waiting at the bus stop for me. I have jobs I need to do. So they're worried about that. And then they find themselves where they don't expect to be, and they try to find their way out to the place they want to be. Depression can sometimes be based on insight and understanding. So the person is aware that they have impairments. They're aware that they're not functioning at the level they want to be. It makes them sad that they can't figure out what to do about that. It can often be expressed as anxiety, so treatable in that fashion. So, persons with depression often express sadness, anxiety, hopelessness, grief. They can be tearful, restless. They can be apathetic and withdrawn. They can have loss of appetite, weight loss, insomnia, or excess sleeping. They can be obsessed. They can be stuck in a loop. And they can be labile. They can be fine one moment and they can be over the top with anger or anxiety the next. I've talked about context, the place, the situation, who was involved. So you're going to go to the doctor's office. You're going to tell them that this is the problem I want treated. And it's, put it in terms of caregiving, put it in terms of what the person is experiencing. The context is every day she says to me that she doesn't know what's going wrong. And then she gets tearful. And then she gets restless. And then she's trying to find something. And she's trying to go somewhere. Okay? So you tell them that story. Those are the symptoms. So oftentimes the disturbance in mood or behavior is because they don't understand context of where they are. So you can say, they think they're at work. We have a lovely guy at the Auberge right now who basically owns and runs the place, all right? And he's hired and fired me several times, Last week it was all about, have you gotten the payroll done? And I said, yes, I've gotten the payroll run. Well, you sure as heck should, because these guys are working their butts off and I want them paid. And I said, I got it, Frank. It's done. All right then. And then he was gone. Okay? They are often expressing delusional thoughts. And we want to argue with them about it. It does no good to say, my mom really needs to know my dad is dead. It's wrong for her to not know that. I mean, she has to understand Dad's dead. Talks about it all the time. I got the death certificate out, showed it to her. She said, you're lying. We had another big argument, big fight, okay? Like with the professor, okay? Don't argue with a demented person. 3 main people to not argue with in my recent experience. Persons with dementia, Mormon missionaries, and people who believe that Bill Gates has put microchips into vaccines. You're not changing any of those people's minds. Places where you often see mood and behavior disturbances, giving assistance. Okay, I keep talking about this bathing thing because it's a big deal. They need to be bathed. And it's a really intimate thing. And normally, people don't want it to happen. Okay? You don't want to be disrobed by another person, normally. In college, it was a different deal for me. Crowds, events, and activities are stressful. Okay? They don't have the ability to catalog what it is we're doing, where it is we are. Who are all these people? I don't know. Okay? You're more likely to find them stressed, anxious, depressed, challenged, labile. Anything that's novel. Any task that requires learning, understanding, and acting. I try to be non-threatening. The first thing I want to know when I'm interacting with a person with dementia is where they are. So I say, what have you been up to today? Okay? A nice open-ended question. Not, did you have eggs for breakfast? Okay? They're incapable of understanding and responding to the environment normally. You have to assume that that's the case. You have to make the assumption that you're going to have to compensate. Okay? When they're experiencing situational problems, they'll express anxiety. They will express delusions. They'll make up their own story about what's going on. They'll make repetitive statements and questions. They'll look tearful, fearful, anxious. They may withdraw. They can respond to the interaction with verbal and physical aggression. So again, I took her out to lunch. She seemed confused by where we were. She didn't understand why we were there. She thought that the waitress was somebody else. She wanted to tell the waitress something and she couldn't express it. She got angry. She looked at the menu. The menu was confusing. It made her anxious. She decided to get up and go before the meal even arrived. Okay? That's the story you tell to the doctor. Who's involved? Family is often the anchor to reality. So this is the savior, okay? This is the person I recognize. This is the person who's going to help me. This is the person who's going to take me home. And then, when you don't take them home, they're angry and irritable and exit-seeking and agitated and hostile and labile. And you get what I'm going after here? What words to use? With family, it's often frustrations. They'll tell them, you know, you really piss me off because I can't get out of here. Somebody who's aware enough that they're not in the environment they want to be will express their frustration, anger, their sadness, and they will often be verbally aggressive. Non-family caregivers can provoke behaviors because they fail to get to know the person. They're not interacting with them in an engaging way. Hello, I'm Steve. I'm going to be your caregiver today. And what that means is that anything you need help with, I'm going to give you help with. Do you need help with getting something to eat? That's me. Let's get something to eat. Hey, your clothes, you know, I think these clothes need to be laundered. Can I help you get out of those clothes so that we can launder them? It's time to take a bath. Hey, you know, things are happening later today. Probably should get cleaned up. You know, we've got an event we're going to have, and so probably need to, you know, clean up, put on some fresh clothes. Can I help you do that? Sometimes it works, but at least you're engaging on their level of engagement. When they interact with other confused people, all bets are off, right? You know, it's like worldwide wrestling potential, you know. Why are you messing with my husband, Charlotte, my mother's name? Bam. Okay. They can also have stranger anxiety. It's lack of insight. They misunderstand the cues, the social functionings. They misidentify the person. Hey, that's my wife. There are people here who've experienced someone else deciding that they're husband and wife with their own husband and wife. Confusion, fear, anger, repetitive, anxious, argumentative, inappropriate. Okay, these are things. You just write the words down. These are the kinds of observations I make. Collecting the facts is like a game of Clue. Okay? Who was involved? Where did it happen? When did it happen? What was going on at the time? What did they say? What were they thinking? I ask this all the time of my nurses, and the new ones are always like, well, what do you mean, what were they thinking? They're demented. I said, no. You're right about that, but they're still a person. Okay? They're living in their reality. You need to find out what that reality is so you can help me help you to do the right thing with the medications. Motive matters. Provoked events are a response to the environment. The environment needs to be modified if possible. Unprovoked events are a response to an internal idea. I have to shut the idea off. Unpleasant. Most events are provoked. Okay? The person provoking it doesn't believe they've provoked it, but they have. Okay? Again, collect the facts. What did the bystanders do? Okay? Surprisingly, the bystanders can make things worse. Had a guy, was in the wrong place. He knew he was in the wrong place. He just wanted to go home. He managed to slip between the first doors and the second doors into the lobby. He was raising hell in the lobby, yelling, etc. Call the doctor because the doctor knows what to do. The doctor walks in. He says, "You're the doctor?" "Yeah, I'm the doctor." He said, "Let me the hell out of here." And he starts chasing me around the couch. Okay, we're literally stop here, go here. All right? So the response of the staff was, all right, it's gang time. And so everybody comes running. One, okay, big burly caregivers. There's 6 of us. Okay, that does nothing more than to make him believe, all right, now they're ganging up on me. So let's have it. Okay? The thing about memory loss is that you can't form new memories, and you tend to forget things. All right? So, the smart thing to do was to clear the lobby and let him sit down and think about his behavior, like we've put a child in the corner, and let him forget about it. You may not be able to do that at home, all right? But you can provoke more behavior with your response than is useful when you tend to gang up. And if you did something and it did work, why did it work? Okay? Because you got to make a mental note of that. And in the caregiving setting, it's like corporate knowledge. If you know that chocolate pudding is the only way to get that person to take their medicines, why do you keep it to yourself? Why not you tell the other nurses?
What happened with that patient?
The police came and he went to the hospital. Okay. Marsden, I'm really running over time. And since doctors are going to have to do the prescribing, and since there are no other doctors besides Marsden here and all he does is surgery, I'm not going to go through the medications. For the organizers of the conference, I'm glad to share these slides to you, and people can have copies of them. They're not proprietary, even though it's taken me 30 years and 10,000 patients to learn all this. Okay, I'm going to quit. I know I'm over time.